Hi, this is Dr. Madden. We have Eben here. We're going to go through some of the major actions of the upper arm and the forearm. First is the bicep. Now, most people are familiar with the bicep, but they don't realize it passes across the joint, this acromial joint, and attaches. And so when it shortens, I want you to watch what happens when it contracts. We have a flexion. Flexion means that angle is reduced, and then a slight supination. And that's because there's two heads to the bicep brachii. Now, let's just take a look at this muscle for a minute. It's considered a prime mover, so it's a major flexor to the arm. But if it's injured, then, and think about it historically, like thousands of years ago, if a muscle was injured, we'd be eaten by the wild dogs unless a signer just picked up the workload. And that's what we have here. The brachialis, which is deep to the bicep brachii right here, is going to pick up some of the workload if the bicep is injured. And the brachioradialis coming across the top here is also going to take care of some of the flexion. So Eben can reach down and grab a hand tool and survive. Now let's look at this brachioradialis. I like this muscle because it's huge. Someone who works with their hands a lot, it's the largest forearm muscle. And it's also the breaking point between the flexors. Okay, so all the flexors are going to be the anterior side. So when these shorten, let's watch what happens. These shorten, we're going to flexion here. And for every muscle action, there's almost always an opposing action, an antagonist. The extender's on the posterior side. See that? Now back to a flexion action, we're talking prime movers. This is the agonist. To bring that arm in extension, we have its antagonist, tricep brachii. Three heads, and it's generally the larger muscle of the three. And so sometimes we have the agonist, antagonist, they're going to switch roles. So right now this is the agonist. The antagonist is going to be the bicep brachii. When it shortens, contracts, flexion. All right, thanks Eben. Thanks for listening.
Nice preview of what this lecture is about. The arms, both the upper and lower. And let's move ahead here. Muscles that move the forearm. So we're talking radius and ulna, two bones. Bicep brachii, which we just examined on Eben. There are two heads. I mentioned this as well. The short head, take a look at the short head on the far right. It's going to originate with the least movable part here of the coracoid, which if you know the scapula, there's two processes on the upper scapula. The acromion, which is the uppermost, and then the choroid, which is below it, coracoid. The long head, let's find the long head here. I'm still in the upper right. Long head is going to originate on the supraglenoid tubercle. Now that's a lot of words, but what it means is supra, above. The glenoid is the shoulder joint. And the tubercle is just a roughened area where that tendon is going to attach. The action I mentioned was flexion and a little bit of supination. It also covers that median nerve, so it has a protective function as well. Median nerve. Brachialis, we saw that previous. It's deep. This doesn't show it well, but really it's the bicep brachii is the superficial muscle, which means it's on top, and brachialis is mostly deep. The brachioradialis, which sounds similar, but now we're looking at the forearm, that's that breaking point I was talking about where the flexors are on one side, extensors on the other. Triceps, we saw this on Eben. Three heads, it can be a massive muscle. The origin of the long head, let's find the long head. Let's cut here, and here it is. It's going to originate on the near the glenoid cavity, so again that's the shoulder joint. The other two, the lateral and medial heads of the tricep, they're all going to originate on the humerus, which is the upper arm bone. And these muscles all insert on this small area called the olecranon process, which is part of the ulna. Think of the forearm that forms the elbow. At the proximal end, there's a process. So a lot of musculature, and I'm going to talk about some of the problems with these insertion sites later. And coneus, is a small extensor, a little bit on the lateral surface. You look at the lower right. And pronator, there's two pronators. There's quadratus near the wrist and the pronator teres. Their function is very similar. They're going to pronate the hand so that the palm faces downward. We do have some medial epicondylitis in many different populations, not just golfers. But in this disorder, it's usually the flexor carpi radialis. What does that mean? Okay, let's look at, it's a flexor, so it's going to be on the anterior surface. Remember even example? So it's a flexor here. Carpi means wrist, so it's going to insert on the wrist. And it's going to extend along the radial bone, radialis. But it may also be caused by the ulnar. Here we have this ligament can also be inflamed. So either one will cause that medial epicondylitis. Lateral, okay, so if you're not sure what the epicondyles are, this is a nice picture of a humerus. We have the medial, which is on the inner side, lateral on the outer side. And so tennis elbow tends to be a lateral epicondylitis, which may be caused by the lateral collateral. See the upper part here, lateral meaning the outside, or some of the tendons, some of the extensors that are going to attach there. We looked at these muscles. I briefly mentioned the flexors on the anterior. Take a look at the far right. So this is the correct anatomical position. So in this position, you can see that these muscles are on top, and that's why they're called anterior. The superficial means they're on top, and in extrinsic mean they insert on the hand, but they originate outside the hand. All right, get some vocabulary out of the way. Flexor carpi radialis. It's going to flex. Okay, I mentioned flex, but it's also going to abduct the hand a little bit. Look to the far right. If you look at the position of the flexor carpi, it's on the lateral surface. So when that muscle shortens, you can just imagine that thumb's going to come up, the hand's going to move out, and that's an abduction. Palmaris longus, which is going to move right into the palm. It's going to adduct, so it's going to slightly pull the hand inwards. It's mostly flexion really, but there is a small adduction. Flexor digitorum, think of digits, fingers, is going to flex the middle finger of each hand, middle joint of each finger. There. We're going to flip the hand over, and now we're looking at the posterior surface. And these are extrinsic still, so they're originating outside the hand. These are superficial, and they're mostly going to originate on the lateral epicondyle and some on the supracondylar process of the humerus. So I mentioned this. So there's a lot of origins on that elbow. That's why I have this diagram. The epicondyle, lateral, and medial. So this is the humerus, radius, ulna, bones of the forearm. Extensor carpi radialis longus is an extensor. So these are all extensors, but there is a slight abduction. So it's going to bring the hand away from the body. The brevis is going to abduct as well. So similar name, just one. Look at the position. Longus here, brevis shorter. Extensor digitorum, I like this name because it's an extender, and look at it, goes right into the digits, the fingers, and indeed it extends the fingers and the hand. Extensor digiti minimi, great name because it's going to extend the little finger, the digiti minimi, little finger. Extensor carpi ulnaris, here we have the ulna, near the elbow. Extensor, and it's going to adduct, so it's going to bring the hand to the midline slightly. Okay. But these are primarily extensors. Intrinsic muscles mean that these insert and originate in the hand itself. So these are, and most of these are going to be on the anterior surface, which means the palm side. And if you look at your own hand, you'll see most of the musculature is indeed on the palm, and if you flip your hand over and look at the top, the anterior surface, most of those tendons are extrinsic. They're moving on into the towards the elbow. All right, so opponent's pollicis moves the thumb across the palm. So opponent's pollicis, here's the thumb, and you can imagine it's going to bring it across. The abductor pollicis, and think of ab is to move away, it's going to abduct the thumb away from the palm. Flexor pollicis brevis flexes the thumb, so you're going to shorten the angle there. And the adductor pollicis is going to adduct the thumb, so it's going to move the thumb towards the midline. Okay, just look at the fibers. Oh, and I don't like the way they label the opponent's pollicis. They make it look like it's the adductor pollicis brevis. The brevis is the larger muscle in the palm, and the opponent's is a little smaller. It's on the periphery here. Intrinsic, we're looking at the adductor digiti minimi, so you can imagine that's going to be a little flexion here, the little finger. There's a brevis as well, and then the lumbricals in between these extensor tendons are going to be involved in flexion. And the opponent's digiti minimi moves the little finger, here it is down below, across towards the thumb. Okay, so just imagine that muscle shortening. That finger has no choice but to go towards the thumb. Carpal tunnel. The main piece in this, well, there's several pieces, but this sheet-like flexor retinaculum, you see it here and you see it down below. This is a dense sheet of tissue which creates a really tight space. Look at the bottom. This is a cross section, so this is a cut across the wrist, and you'll see the tendons and there's sheaths as well. The sheaths are there to provide some sliding action. And here's a median nerve, which I cut the word off a little bit. It's yellow, and that's the problem, because look at, there's not much space for inflammation. So if we have some trauma, someone falls, or repetitive action, and there's some inflammation, there's nowhere for it to go. And so now these tendons don't get to slide back and forth without a lot of pain from the median nerve. We try to splint it, maybe cold pack it, corticosteroids to shrink the tissue, and that can work. And if that fails, then this retinaculum here is cut, and so we get a little space. It's just about providing space so that the tendons can slide back and forth, and the median nerve is not under pressure. All right, thanks for listening.